Good afternoon, everybody. I will just take a minute as folks start chiming in. Welcome to today's session. All right. Hello, and welcome to the second webinar of the low-dose aspirin LDA campaign webinar series. In this session, we are focusing on preventing preterm birth and preeclampsia. How can pharmacists help? My name is Noel Ashby-Roslin, and I am the comms specialist at CMQCC. And before we introduce our esteemed speakers, we'd like to go over some housekeeping rules and information about CEUs. All attendees are muted upon entry. This will help minimize any background noise and ensure that our speakers can be heard clearly as this session is being recorded. Do please use the Q&A function, and we will do our best to answer your questions during this session. After this webinar, you are more than welcome to use any of the slides provided for educational purposes, and your feedback is really important to us. And so if you have any recommendations that might help us inform to improve our future webinars, that is much appreciated. And here, please take a moment to review our inclusive language notice. I won't go through and read these bullet points, but they are here and will be available when we do share out the slide deck after this webinar. Thank you. So for credits, attendees will be eligible for contact hours. To receive contact hours for this webinar, please complete the evaluation form, which will be provided at the end of this session. You must be in attendance on this webinar live for a minimum of 50 minutes, and you must be signed in under your own account for contact hours to be awarded. Unfortunately, we do not offer contact hours for on-demand webinar viewing. And here up on the screen are the webinar objectives. I'll go ahead and paste them into the chat function just so that you can reference back on them as needed. So let me just do that right now. And now I'd like to introduce today's speakers. We have Dr. Lindsay Duplessis, Community Engagement Lead at CMQCC, Dr. Joyce Huang, Global Health Economics and Outcomes Research Lead at AbbVie. Dr. Huang received her Doctor of Pharmacy and MBA from the University of Maryland. She currently leads a team of health outcomes researchers at a pharmaceutical company. Her interest in maternal fetal health began in 2010 while studying VEGF, PLGF, as biomarkers of preeclampsia. She is now a mother of two and an advocate for improved access and outcomes for all expectant mothers. We also have Dr. Gina Ahmadyar, Health Economics and Outcomes Research Manager at AbbVie. Dr. Ahmadyar is a registered pharmacist in the state of California. She currently works in the pharmaceutical industry as a manager of health economics and outcomes research, and is passionate about causes related to women's health and underserved medicine. And now I'd like to turn it over to Lindsay.
Thank you very much, Noel. All right, next slide, please. All right, welcome everybody. Good afternoon. Thank you for joining today. So first and foremost, I'd like to say that this low-dose aspirin pilot project has been generously funded by the March of Dimes. So thank you so much to MOD. Next slide, please. So I'm sure most of you have heard of CMQCC. It stands for the California Maternal Quality Care Collaborative. CMQCC was founded in 2006, so celebrating about 17 years at Stanford University School of Medicine, together with the state of California in response to rising maternal mortality and morbidity rates. And the mission of CMQCC is really to end preventable morbidity, mortality, and racial disparities in California maternity care. CMQCC has a formula that combines outreach and stakeholder wisdom with research and data into quality improvement toolkits to address pressing threats to maternal health. And lastly, it's an effector arm of the March of Dimes Prematurity Research Center, which is currently funding the LDA work. Next slide, please. So here's a list of the pilot hospitals that are part of our low-dose aspirin campaign. We have been collaborating with them as well as their associated clinics. This was our first cohort, and we will be starting our second cohort soon. And so as you see here, we have most of them are in Southern California. We have Loma Linda University Children's Hospital, Riverside University Health System, Medical Center, Scripps Chula Vista, UC San Diego, and then we have one in Sacramento, Mercy San Juan. So as Aaron Noel mentioned earlier, this webinar is part of the LDA campaign series. This is our second one. We had our first one back in December, and the remainder of the series will be on the following topics: midwives and doulas, clinical, as well as patient. And so webinars will be open to anyone who is interested in the campaign and promoted on our CMQCC website, social media pages, and invitations will be sent to all of those registered MDC users. So please keep a lookout for those. And then now I would like to launch a quick poll. So this poll is to see if you are currently recommending LDA for actually preventing preeclampsia and preterm birth to your patients. So take maybe a couple seconds to answer this question. Wonderful. All right, great. Thank you so much. So now I am excited to turn it over to Dr. Joyce Wong. Thank you so much, Joyce. Take it away.
Thank you, Lindsay, for the kind introduction. What a privilege to be here and to be part of this amazing initiative. My name's Joyce Wong. I'm a pharmacist by training, and I'm also a survivor of pregnancy complications. Personally, I have greatly benefited from excellent healthcare during my birthing experience. So it is now my passion to see that all expectant mothers also have access to excellent healthcare. For today, we're going to do a few things. I'll start with the background on preeclampsia. Next, Gina will cover the benefits of low-dose aspirin, and we will come back to review some FAQs and to open up the line to gather your thoughts and inputs. Okay, next slide, please. Here's a legal disclaimer slide, which I will read to you, so bear with me. The slide set is considered an educational resource, but does not define the standard of care in California or elsewhere. Readers or you are advised to adapt the guidelines and resources based on your local facility's level of care and patient population served. And you are also advised to not solely rely on the guidelines presented here. As a personal note, Gina and myself are volunteers for CMQCC. We contributed to this program in our personal capacity. So the views and opinions expressed here solely belong to the speakers, and they do not necessarily reflect the views of our employer, AbbVie Pharmaceuticals. Okay, next slide. Now let's get started because we have a lot to cover today. First, let's go over some background information. We're going to talk about what is the burden of preeclampsia, what is the role of the pharmacy, And how is preeclampsia diagnosed? Okay, next slide, please. We'll first start with the burden of preeclampsia. Here's a report from the CDC. It shows the growing trend of pregnancy-related mortality ratio for the past decade, between 2012 and 2020. And sadly, the numbers along the lines represent those mothers who died for every 100,000 live births. Imagine the children and families that have been left behind. And as you can see in the red line on the top, this is the national average. It has been steadily climbing from 15.9 to 17.6 deaths. This is an alarming trend, especially given that we are in a such highly developed country where we enjoy abundance in technology. Now look at California, which is the blue line on the bottom. California's rates are lower than the US, but it's also been rising. The rate spiked during COVID year to 18.6, which is a dramatic increase compared to the mortality ratio in 2019. But even after adjusting for COVID-19 deaths, the mortality rate in 2020 still would have been 15. So in a nutshell, this chart points to a real concern. Next slide, please. Now let's look at the most common causes of pregnancy-related deaths and their timing in California. From the most common to the less common causes are cardiovascular disease, hemorrhage, infection and sepsis, hypertensive disorders like preeclampsia, thrombotic pulmonary embolism, and amniotic fluid embolism. Okay. And what about the timing? So notice that majority of the deaths occur on the day of the delivery or up to 1 year after the pregnancy ended. So that is from day 0 to day 360. This tells us that continuing to follow up the patient and monitoring even post-pregnancy is critical. Okay, let's move on to the next one. Next slide, please. What's making the situation even worse? Now, in this slide, I will show you a serious inequality in healthcare access by race and ethnicity. In the same time period, Blacks in California had the highest rate of mortality compared to other races, like Hispanics, Asians, and whites. That's shown in the red bars on the right of each cluster. Okay, this disparity is 3 to 6 times higher. So by now, you're probably feeling disheartened like myself. As a healthcare provider, we really need to recognize the situation and address it appropriately. Okay, next slide. So, so those were the statistics. Going beyond that, our experiences are also telling us that we need better education. So this sign in front of you has been placed in a large and well-respected healthcare provider office. It specifically said that aspirin is known to the state of California to cause cancer and birth defects. It is especially important not to use aspirin during the last 3 months of pregnancy because it may cause problems in the unborn child or complications during delivery. Major red flag. But luckily, Lindsay and the community lead at the institution, they came across the sign and they intervened. So now this provider network is taking out the word aspirin from the sign. This is a huge win, and we hope to continue this momentum. Okay, next slide. Okay, now what does all of this have to do with the pharmacy? I would say a lot. As a pharmacist, we work in the front line, and we directly face the community and people in childbearing age. We provide essential care. And the best thing is pharmacists are highly trusted and accessible to the public. This is something that we should all be proud of as pharmacists. And up until now, the pharmacy community hasn't been very active in the prenatal care. We also haven't been very involved in preeclampsia prevention. But we think this is about to change. Why is it about to change? Because in California, pharmacists are now able to prescribe birth control. So this opens up a new opportunity to be involved in preconception care. Okay. Let's go to the next slide. So taking a step back, what is the major challenge with preventing preeclampsia? It is finding the patients early. Preconception care is an important window that allows us to find those patients early and subsequently reduce the risk of preeclampsia. It's important to educate everyone in the childbearing age, that's defined as late teens up to age 50, not just those planning to become pregnant. And as pharmacists, we can help incorporate preconception care in our everyday interactions with the patients and the public through the health education and screening. Okay, next slide, please. Okay, we have just talked about the role of pharmacies. Now let's dive into the disease itself. What is preeclampsia? Okay. Preeclampsia is a serious hypertensive disorder in pregnancy that can lead to major organ damage, such as in the kidneys, liver, heart, and or the brain. It starts at 20 weeks of gestation, but can also happen during labor or after the baby is delivered. So remember the previous slide on the timing? The vast majority of the deaths occur after the baby has delivered. Now let's look at the consequences. Preeclampsia can lead to severe consequences for the mother. So the complications include seizure. You may have heard of eclampsia, which is preeclampsia plus seizures, and stroke, death, or increased long-term risks for heart disease and diabetes. Okay. And for the baby, preeclampsia is also harmful. In preeclampsia, there is a disrupted blood flow to the placenta. So the patients are more likely to deliver the baby preterm. And these can translate to poor outcomes for the baby. Okay. Next slide, please. Now, what are the hallmarks of preeclampsia? Okay, so let's talk about some diagnostic criteria. First, there is gestational hypertension, defined as 140 over 90 or greater after 20 weeks of gestation. The blood pressure is taken on 2 occasions at least 4 hours apart. And notice the onset must be 20 weeks or later for it to be gestational hypertension, which is different from chronic hypertension that can happen even before pregnancy. Now, the other hallmark is proteinuria. Proteinuria can be measured by 24-hour urine collection with a protein over 300 milligrams or protein creatinine ratio of greater than 0.3 or dipstick reading greater than 2. Okay, so these are classic hallmarks of preeclampsia. However, it's can be tricky because preeclampsia sometimes can be diagnosed without proteinuria. And in this setting, gestational hypertension is accompanied by any of the following: thrombocytopenia or decreased platelet count, renal insufficiency or impaired liver function, pulmonary edema, which can present in dyspnea, new headache that does not respond to medications, or visual symptoms such as blind spots and blurry vision. Know that these symptoms are not normal in pregnancy. And if your pregnant patient comes in with these complaints, please triage immediately. Now, next slide. Preeclampsia can also progress into preeclampsia with severe features. So those severe features include hypertension of greater than 160/110, again, measured on 2 occasions at least 4 hours apart. And the rest of the lab measures and symptoms are the same as the previous slide. Now that we've just gone through the hallmarks of the disease, let's talk about how to identify these patients early. I'll turn the discussion over to Gina.
Thank you, Joyce. And before I get started, I just want to begin by saying it is such an honor to be here today to help educate and just raise additional awareness on this very, very important topic. And so for today, next slide, please. I'll be going over how we can identify who is at most risk for preeclampsia and what some of the benefits of low-dose aspirin are to help prevent it. Next slide, please. Listed on this slide are some of the risk factors for preeclampsia that are considered high risk factors. And it's recommended that individuals with even just one of these should be receiving low-dose aspirin. And this includes having had preeclampsia in a prior pregnancy, having a multifetal gestation, having chronic hypertension or pregestational type 1 or type 2 diabetes, kidney disease, autoimmune disease, or a combination of multiple moderate risk factors. Next slide, please. And these moderate risk factors are listed here. This includes it being the mother's first birth, the mother being obese prior to becoming pregnant, having a family history of preeclampsia with a first-degree relative, being from the Black race, and this is more so from the lived experience and a consequence of a lot of the health and social inequalities faced by this community rather than from like a biological standpoint. If the mother has experienced financial hardship, or if she's age 35 years or older, if she herself was born with a low birth rate or had previous adverse pregnancy outcome or in vitro conception, or if it's been more than 10 years since her last delivery, it's recommended that individuals with 2 or more of these moderate risk factors should be receiving low-dose aspirin. Next slide, please. So now that I've gone over how we can identify who's at most risk, I will now be discussing what we can do to help prevent preeclampsia. Next slide, please. So it may not be a surprise based on everything that's been discussed, but low-dose aspirin is the only known way to reduce preeclampsia and mother and infant harms that result from it. Next slide. And although the exact mechanism of how aspirin helps prevent preeclampsia isn't well known, it's believed that through its irreversible inhibition of the COX-1 enzyme and the resulting anti-inflammatory and antiplatelet effects, aspirin helps support the healthy placenta development, preventing changes that can lead to high blood pressure. And what this results in is that those taking aspirin are more likely to deliver at full term and less likely to have preeclampsia. Next slide, please. And there's been a ton of data to help support this. So in 2014 and again in 2021, the U.S. Preventive Services Task Force came out with a recommendation statement based on a systematic review of many randomized controlled trials that included over 25,000 pregnant individuals. And they basically concluded that there was a net substantial benefit of using aspirin to help prevent preeclampsia and related morbidity and mortality. Additionally, many groups such as the ACOG, the Society for Maternal Fetal Medicine, as well as the WHO and the AHA have all recommended the use of low-dose aspirin during pregnancy. And what these national medical and patient organizations have concluded is that the daily use of low-dose aspirin starting between 12 and 16 weeks of gestation has substantial benefits for both mother and infant. Next slide, please. And to quantify what these benefits are, the data has shown that low-dose aspirin given to those at risk for preeclampsia has been shown to reduce the risk of preeclampsia by 15%, reduce preterm birth by 20%, fetal growth restriction by almost 20%, and perinatal mortality by more than 20%. And ultimately, what these numbers result in is healthier moms and healthier babies. Next slide. Unfortunately, despite all this data, these recommendations have been slow to become widely used. Multiple studies find that less than 25% of eligible women are offered to take low-dose aspirin. Additionally, women with chronic hypertension who are among the highest utilizing group, only about 50% of them end up taking low-dose aspirin. And among Black pregnant people who are eligible, only 10% receive low-dose aspirin. Next slide. What this shows is that current medical information and prescribing are not enough, and patients are experiencing many barriers to adopting this. Listed on this slide are a few barriers that we've seen, and I'd like to take a moment to pause and encourage individuals to type in the chat any of your own personal experiences from either personally or professionally of some barriers that you've seen, or if any of these listed here really resonate to you. I know personally as a pharmacist, one that stands out is this one about difficulty obtaining prescriptions. Many patients actually aren't aware that low-dose aspirin is available over the counter. And quite frankly, many patients are confused by all the different nomenclature that's out there in terms of baby aspirin or low-dose aspirin and may not realize that they're all referencing the same product. Another one that really stands out is this perception of mixed messages among healthcare providers about aspirin safety. And Joyce even showed us an example of that on this that sign that was listed in that health office earlier in this webinar. Ultimately, what this says is we really need to come together as pharmacists, as healthcare professionals, to educate our patients and our colleagues about preeclampsia and the use of low-dose aspirin to help our patients overcome these barriers. Next slide, please. I also want to mention that there are some cases where low-dose aspirin may not be recommended. And that's if a patient is contraindicated. Erin, I think this is like a click through on this slide. Yes. So contraindications to aspirin include having a known documented allergy to aspirin or an NSAID, or having had a history of an aspirin-induced attack such as asthma, rhinitis, nasal polyps, or acute bronchospasms. Additionally, aspirin may not be the right treatment if a patient has GI bleeding or stomach ulcers, if they have low platelets, have had gastric bypass surgery, or if they had experienced first trimester bleeding. Next slide, please. So what can we do as pharmacists, as healthcare professionals? Well, first, we can start proactively educating our patients, our family, our friends about low-dose aspirin and about preeclampsia symptoms. We also should educate our patients on the importance of monitoring blood pressure during pregnancy. And this can be as simple as just asking a question of, hey, when's the last time you've measured your blood pressure, and starting the conversation that way. Additionally, it's important to share key messages with our patients when talking about low-dose aspirin. And this is that low-dose aspirin is safe to take among all different races and ages, and that it can make pregnancies last longer and keep moms and babies safer. Lastly, when counseling patients on taking low-dose aspirin, it's important to emphasize that they should be taking it daily. Next slide, please. And before I close off, I just want to say that there are a ton of great resources out there to help incorporate this into your clinical practice. This is an example of a checklist from the Society of Maternal and Fetal Medicine that I really like. It's a self-administered form, and patients can fill this out and help you evaluate who is eligible for low-dose aspirin. It's available online, and it could be something helpful to just have a few copies laying around to help open the discussion with your patients. And with that, I will turn it back to Joyce, who will go over some FAQs.
Great. Thank you, Gina, for the fantastic information. As promised, now let's look at some FAQs. We'll open up the line for discussions and questions from the audience. And I know that we have already been receiving some live questions and been trying to answer them live as well. So to get us started, next slide. FAQ number 1. Is low-dose aspirin safe in pregnancy? The answer is yes. When there is no contraindications, low-dose aspirin is safe. There is no evidence to show that aspirin increases the rate of maternal harms, including placental abruption, hemorrhage. These are not increased. And there's also no evidence to show that it increases the rate of fetal harms, like congenital malformation, premature ductal closure, or bleeding. Okay, again, it's safe when the patient is not contraindicated. So we want to review those contraindications with the patient before making the recommendation. And most of the concerns that we have heard are related to the full adult doses, okay? And that is at 650 milligrams per day. But at that dose, there's a different biochemical effect, and even the effects are modest. Next slide. Okay. FAQ number 2. What is the optimal dose of LDA? Okay. We recommend taking 1 tablet, which is the most common formulation, dosage at 81 milligram per day. And this is consistent with the recommendations from USPSTF, that's the U.S. Preventive Services Task Force, ACOG, or the American College of Obstetricians and Gynecologists, and guidelines from SMFM, or the Society for Maternal Fetal Medicine. Again, 81 milligrams per day. And we also wanted to share with you another supporting evidence, which comes from a large multi-center placebo-controlled trial that was published in the New England Journal of Medicine in 2017. In this trial, they included more than 1,700 women with very high risk for preeclampsia. And these patients were randomized to receive either the placebo or 150 milligrams of aspirin daily. And they started the medications from 11 to 14 weeks until 36 weeks of gestation. The primary outcome measure was preterm preeclampsia. And the study shows that in the group that received active treatment or aspirin daily, 1.6% had developed preeclampsia or preterm preeclampsia. And this is compared to the placebo group outcomes, which is 4.3% had developed preterm preeclampsia. The odds ratio was 0.38. So what does this mean? It means that taking aspirin slashed the risk of preterm preeclampsia by 62%. And the results are statistically significant between the groups. Also, note that there were no significant differences in adverse events. So the rate of adverse events were similar between placebo and aspirin. Okay. Quite encouraging. Now, next slide, please. FAQ number 3. When should LDA be started and stopped? Now, we see the greatest benefit with low-dose aspirin when starting between 12 to 16 weeks or at the beginning of the second trimester. Okay? But even if you start as late as 28 weeks, there's still evidence to show modest benefit. So we recommend the expectant mother taking 81 milligrams daily, continually until the delivery. And I will also insert a little tip. The best time to take it is when the patient remembers to take it. If somehow the patient needs to be on higher doses, such as 2 pills or 162 milligrams per day, then in practice, we recommend stopping at 36 weeks. So this is to avoid potential concerns over epidural or anesthesia complications. And note that this last bullet is based on opinions. All right, now let's move to the next segment. We have just gone through the FAQs. We will now do a fun exercise because we are just starting to reach out to pharmacies. This is a new initiative. We recognize that there is still so much blank space out there, and we need to learn together as a community. I will now throw in some questions for a thought exercise. Please type in your answers into the chat. Okay. The first question is, what are some ways you can identify women for preconception care? Okay. We need your thoughts here. And please don't be shy and go ahead and type your suggestions into the chat. Any takers? What are some ways you can identify women for preconception care? Oh, audience said the chat is turned off. So maybe we have, maybe we need to kind of go over the instructions again. I think the audience just needs to open up the Q&A. It is on now. Okay, great. Early prenatal care, yes. So for example, if you come across a patient that is buying prenatal vitamins or perhaps buying pregnancy tests, these are some indicators that they are in that preconception stage. Excellent. Anybody else? Folic acid. Yes, discussing all annual exams, including well woman exams. Yes, that's a great opportunity to bring up preconception care. And identify patients who quit buying or filling birth control. Oh, that's a very good one. Anybody of childbearing age is a candidate, yes, for counseling or preconception. Agree. People who stop taking birth control. Okay. Purchasing prenatal vitamins and pregnancy testing. Great. Population, maybe education on schools. Okay. All right. I think these are all wonderful suggestions. Oh, IVF meds education. Yes, it's a time for education when you see patients filling IVF meds. All right. We'll continue to collect chats, collect your thoughts and ideas. I'll go ahead and move on to the next question. How would you introduce the topic of pregnancy complications, such as preeclampsia, misstepple, removal of IUD? Yes, so stopping birth control is a great kind of indicator that the patient is in preconception care. Okay, and now you have identified a kind of potential patient or candidate. How would you bring up the concept of preeclampsia? I know this one could probably use our previous webinar on discussing preeclampsia respectfully. Ask patients how the pregnancy is going. Yes. Prenatal first visit with history. Okay. Hidden disease like hypertension, watching for signs. Okay. And no one wants and plans pregnancy issues, but they can happen, but they are more likely without advanced planning. So perhaps we want to refer back to that list of patients with high risk, right? The risk factor slide. That includes their kind of demographics and also clinical factors. Demographics are like if this is their first birth and if the patient is obese, or if they have a family history of preeclampsia or Black race, just as a construct, social construct for increased risk of preeclampsia. Financial hardship, advanced maternal age, patients born with low birth weight or previous adverse pregnancy outcome, IVD or IVF conception, or more than 10 years since the last delivery. So if we want to go back and re-review the slides from Gina, I think that would also be a great way to identify patients we want to focus on for this discussion. Ask them if they have a history of elevated blood pressure. Yes, African-American women. And reviewing the risk factors that we just discussed, and just be, I think, very sensitive of the fact that the structural racism has really exacerbated the issue. Okay. All right. Anybody else? The post, oh yeah, we can put up the posters in the pharmacy and in bathrooms to drive awareness. Okay, so that's kind of moving on to our next question. What additional tools or avenues, like opportunities, can you use to engage more pharmacies on LDA? So I already saw one, the posters at pharmacies and bathrooms. Patient education materials, perhaps. Mandated trainings with pharmacies. Okay. Any other tools that you would recommend that we start to implement? More webinars like this one. I like that. Okay. Preeclampsia history. Okay. So perhaps even more webinars at various kind of pharmacy conventions or pharmacy societies, and including these into potentially pharmacy school materials, which has been a bit of a blank space in my personal experience. We just don't discuss this topic enough in pharmacy or even at school. Inpatient, perinatal patient navigators, home visitation services, yes. National campaigns on TV, okay. Direct to consumer campaigns. Right. Presenting to the APHA chapter in California with live CE events. Yes, that's a great one. As a nurse educator, and this will be added to your lecture in the clinical material. Wonderful. We love to share our content with you to get the words out there. And if we can identify women by risk factors and use the education and implement LDA, we will see an improvement, absolutely. Just getting the words out and raising awareness is already a huge step. Okay. Tier PAT checklist by pregnancy test and vitamins. Okay. Wonderful. So I really, really appreciate these suggestions. These are fantastic suggestions to help us kind of think about how to further reach the pharmacy community and also improve our future campaigns. So with that, we'll move to my final slide, which is just questions. We have a few minutes left. What other questions may I answer for you? I'm just looking at the chat quickly. Upload a link to the checklist for, okay, one question is, can you upload a link to the checklist for eligibility for the use of LDA? Yes, and we can work with Lindsay, right, to upload the checklist to the CMQCC website. And we can send a follow-up message after the call to this audience specifically. Okay. Lindsay, is there anything else you would like to add in terms of making our tools available?
I'll get to that on the last couple of slides.
Okay, great. And I really love this kind of last chat on my screen. Sylvia mentioned teaming up with community groups to share this information. There are many community groups working on disparities in maternal morbidity and mortality. This is wonderful.
And Joyce, I just want to add, so I'm typing away and trying to answer everyone's questions as quickly as possible. So we'll continue to answer your questions, keep them coming. I just want to say there's been some great stories, some great insights. So thank you for everyone for sharing your experiences. So we'll be typing away and hopefully addressing your questions as they come in, but just wanted to say thank you everyone for sharing and asking away. This has been great.
Yes, it's such an engaging audience. We love it. So I think with that, we have a few minutes left. I will turn this back to Lindsay to kind of walk us through the next steps and close out.
Thank you, Joyce. Next slide, please. All right, so I know many of you have mentioned in the chat to have some handouts and things like that. And so here you can see some of our patient education materials, which are actually in English and Spanish, and we will translate into additional languages as we continue to scale up. We continue to identify and/or fine-tune community messaging and outreach materials to educate women about the role of low-dose aspirin during pregnancy. So here you can see an information sheet and a poster. And you can also see here that the education materials feature a QR code that takes the patients to the March of Dimes website to learn more about preeclampsia and the benefits of LDA. And we love QR codes because, as everybody knows, everybody has a cell phone. So it's really easy to access this information. So these materials are posted in the clinics and the hospitals that I mentioned earlier. And what's really cool is that they are in elevators. So not only, birthing people and pregnant people are seeing this, but maybe like a grandfather or a cousin to really spread the word about low-dose aspirin, because preeclampsia and low-dose aspirin are not often talked about. They're also in waiting rooms, and they're also in areas where patients are getting their blood pressure checked. And I'd also like to point out that we have a patient advisory committee, and that is consisting of patients with lived experience who delivered at or near the pilot hospitals that I mentioned earlier. They have met with the pilot hospital leads to collaborate and truly enhance the importance of patient and community voices. And currently we have about 12 patients that are serving on the committee. And I want to point out that they have had their eyes and input on these materials. So they helped to design these materials because we really wanted something that truly resonated with patients. We also have a scorecard as well that's not listed. Next slide, please. All right, so just some information about the recording and webinar evaluation. So at the end of this webinar, please click the evaluation link provided to submit your evaluation for this webinar, or you can scan this QR code that you see here. It's really important for your contact hour that you do complete the evaluation. And once the presentation is over, you will get a pop-up with the evaluation. Also to note, the webinar recording and slides will be posted on CMQCC's website. And you can also access the patient education materials. So please go to the website, print them out, post them. Another important thing to note is that we have had some of these folks on our patient advisory committee to tell their stories. And so we have some articles online as well. So please take a look at that. Next slide, please. So thank you for joining us. As I mentioned, we will continue to have more webinars, future webinars. I have my email address listed here. If we are unable to answer your question, please do not hesitate to reach out to me and we will get that question answered for you. If you have any questions about the campaign, anything like that about patient education materials, please feel free to email me. Next slide, please. So here, we would love for you all to continue to follow us on LinkedIn, CMQCC's website, Facebook, Instagram, where we will promote future webinars. All of our patient education materials are are listed and available on this website. So please make sure to stop by and check it out. Thank you, Aaron Noel. He said you will get a pop-up with a link to the survey once the webinar session ends. So I just want to thank you all for attending. You know, it's really, really important to educate and get the word out. We have to educate everybody, patients, communities, you know, clinic folk. We can't stop. This is really important. Such an important topic that is not often discussed. So I want to once again thank you so much to Dr. Huang and Dr. Ahmadiyar and Aaron Noel. Thank you so much. And I just want to point out that they are volunteers. They volunteer with CMQCC. So thank you so much for your time.
Thank you.
Thank you, everyone. And I see that you're not able to scan the QR code. Aaron Noel, is there a way that they can get this if they're not able to scan it? The pop-up, correct?
That's right. So you'll get a pop-up once the webinar ends, and I'll do that right now. Thanks, everyone.
Thank you so much. Have a great day.